Hi and welcome back. This is the second part of our offer hold a day experience, and we'll look to try and do some more practical elements where we can in this presentation and get you folks to do a little bit of work at home as well using the workbook that you have access to online. If you were doing this as an on-campus experience, we'd obviously have you in our physiotherapy labs by this point, and you'll be doing some of these practical elements on each other and experiencing some of the things that our students would learn to do in our practical sessions. As you can see, this is our physiotherapy lab. The last time you would have seen one of these would have been during your interview. So this is a much less stressful environment, hopefully. And again, you can see how it will be set up for a normal practical session that we would teach at the University of Hertfordshire. Obviously, the kind of weird view is because this is taken with a fisheye lens to try and give you a bit of a 360-degree look at it. So if you can open up your workbook or have it accessible on your device or perhaps a hard copy, we'll try and work through some practical elements and pick up on where we left off from the theoretical side of looking after Mary and her case scenario in the earlier presentation. So you can see on the screen here, I've given you some pictures of some bones, which again, normally you'd have hands-on to have a little look at. So what I'd like you to do in a moment or two is just to pause this presentation and try and work out what the bones are. Try and think about how you might orientate them, which way's up, which way's down, which way's left or right. And if you can, perhaps just label them in your workbook. If you've got a name for the bones, try and jot them down if you know what they're called, or if you can have a bit of a guess. And again, if you can, have a quick sketch. See if you can't align these bones correctly to form a lower limb or a leg. And then finally, if you can, have a little think about what joints might be formed. So again, do pause this now, have a couple of moments just to work through that, and then we'll move on to the next slide when you're ready. Okay, once you've done the bony anatomy, now let's have a little think about the muscle anatomy. And again, this is exactly how we do it with our students. Once we've done some of the theoretical work, we now need to look at the actual practical anatomy. So now we're working again on the lower limb, as this is where Mary's problems tend to be. So now let's have a little look at these muscles. See if you can work out what these muscles are called. Again, think about perhaps your prior knowledge or experiences or learning from science, biology, PE, or perhaps if you're not sure, have a little look at any online resources that you might have access to. Have a quick Google search, see if you can find out what these muscles are called. And again, pause this presentation for a few moments, just so you can work through that and see if you can come up with some answers. And then we'll move on to the next slide, where we'll go through the answers of the bony and the muscular anatomy. Okay, so hopefully if you've had a chance to do some work in your workbook, you can see that this is how the lower limb should look. I'm afraid the proportions aren't exactly correct here because I've had to kind of cut and paste and shrink and move some of the pictures to make them fit. But you can see here generally how the lower limb would look from the bony anatomical viewpoint. So did you manage to label these bones? Well, let's have a little look and see how well you've done. What's this big one up here called? This top bone, if you like, this irregular shaped bone. Okay. So this is called the innominate bone or the hemipelvis. This is half a pelvis. This is what forms half of your pelvic girdle. The next one down, again, this is the big thigh bone, or what we call the femur. This is the longest bone in the body. The next one we've got is the patella or the kneecap, and you can see how this fits in between the knee joint just here. Can you see? So again, that's actually at the front of the knee, which is why I've not been able to place it on this picture. The next one down, again, we're looking at now the shin bone or the tibia. And again, this is quite a strong bone, quite a long bone, not quite as long as the femur. And on the lateral side, on the outside of that bone, is the fibula. So these two bones form the lower shin part of your leg. Then underneath that is obviously the foot. That is many, many bones in the foot, so we're not going to label all those, but the foot is good enough for our purposes. So hopefully you've got something like that in your workbook or in your mind's eye. So what joints are there in the lower limb? Again, our students would need to know this and understand the anatomy of these and how they work. So the first joint is what we call the acetabulo-femoral joint, or the hip joint. You can see here, the big ball and socket joint that allows the leg to move up and down, forwards and backwards, in and out, and rotate. The next joint down is called the tibiofemoral joint, or the knee joint for the layman. And again, this allows the leg to move forwards and backwards, what we call flexion extension, and acts a bit like a hinge joint. The next joint is the patellofemoral joint, and this is where the kneecap articulates or sits on the front of the thigh and the shin bone, just over the top of your knee. The next joint down is called the tibiofibular joint, and there are two of these, as you can see in green here. At the top, the superior, and the bottom, the inferior aspects of the tibula and fibula. And finally, the bottom joint is the talocrural joint, or the ankle joint. And as you know from moving your foot, this is a very flexible joint and allows movement in multiple planes. So hopefully that's how your kind of workbook looks. Let's have a little look now at musculature. So again, did you have any luck naming these muscles? Well, let's see. This one here is called sartorius. This is the front of the leg, and this is the inside component leg running from out to in. This is what used to be called the tailor's muscle. If you can imagine crossing one leg over the other, this is how tailors used to sit to sew, and this muscle allows that movement of rotation and bringing the knee and the shin up to the other leg. The next one down is the rectus femoris. This is the big thigh muscle on the front of the leg, and this is part of the quadriceps group. Quadriceps because there are 4 muscles that compose this big group of muscles that allows the knee to straighten strongly. Another component of the quadriceps is the vastus medialis muscle just here. We have vastus lateralis on the other side as well, which I can just highlight here. This is the vastus lateralis, and underneath the rectus femoris is also another muscle called the vastus intermedius, and that composes the 4 muscle groups of the quadriceps muscle. Okay, so let's think about the back of the leg now. What's this big muscle up top on our bottom? That's called the gluteus maximus, and is actually the biggest bulk of muscle in the human body. And this allows us to straighten our leg behind us, so bringing our heel backwards towards our bottom. The next 2 muscles down are part of the hamstring group. And again, the one on the kind of inside of the leg, if you like, or closest to the midline, is the semitendinosus muscle. Next door to that is the biceps femoris. Biceps means 2, and again, the bottom of this muscle splits into 2 to join into different areas of the lower limb. Finally, down the very bottom, the calf muscle is called the gastrocnemius. This is a big, strong muscle that allows you to go up on your tiptoes. It kind of allows the foot to push down strongly onto the floor and can lift the entire body weight, as you can prove by standing on tiptoes on one leg if you choose to. So again, hopefully you've got a bit of an idea of how we now think about muscles and how we need to know the bony anatomy and the soft tissue and muscle anatomy of the lower limb in order to be able to treat someone like Mary. So our students would learn all this both in the practical sessions and independently in their own time and kind of share their information. We'd also need to think about learning not only about the soft tissues and muscles, but also about the nerves that supply the muscles. So we need to think about the muscle anatomy and how that's innervated or kind of starts to work by the nerve. So again, we look at what we call the perimysium, the mysium and the epimysium, which are the different surrounding structures in the muscle belly. And you can see here there are lots of small individual structures which make up one muscle or myofibril. Okay, so again, there's lots of information that we need to think about in terms of how we would ascertain this information. We'd also need to think about the nerves that supply the muscles. And again, we can see in the top right hand corner here how the nerve or the neuron would come down from a central spinal cord or perhaps the brain, and messages would pass down the axon to fire the muscle, make it contract. And we can see in the middle picture, this is called the motor unit, the connection between the neuron or the nerve to the actual myofibril or the muscle strand, which is clumped together to form the muscle belly of those muscles. So again, our students need to understand how that nerve transmission works, how the muscle is fired to work and perform an action such as straightening or bending your knee. So lots of things we need to learn about in terms of the soft tissues of the muscle, the nerves, as well as our bony anatomy. So once we've got a bit of an idea about what we need to now think about is kind of think about the problem solving aspect. So what happens when something interrupts this neuromuscular pathway, when something stops the nerve propagating the pulse or the impulse, if you like, down to the muscle to get it to work. So if we think back to Mary in her case scenario, she's talking about a weakness in the muscles. Do you remember? And again, that's associated with a loss of sensation from the nerves. And we surmise that perhaps the poor blood flow is stopping the nerves from working so well, both in a sensory capacity to actually feel sensation, but also from the motor function to try and get them to fire the muscles. And because she's got diabetes and peripheral vascular disease, this kind of lack of awareness of the nerve working, if you like, and this lack of sensation is called a peripheral neuropathy that we're suspecting Mary may have. So in this situation, what happens, we can see that the nerve tends to shrivel and die because the blood supply has been reduced to the nerve. It doesn't work so well. and that will then stop the transmission of the nerve impulse from the axon, from the neuron, down into the muscle belly, the motor unit, and firing off those signals to make the muscle contract. So if that's the case, and we've got problems with the neuromuscular pathway and transmission of impulses, as physiotherapists, we need to think, how can we manage that? So we would need to carry out some tests to find out how that nerve is working and if there's a deficit and what that might be. So we'd teach our students some various assessment techniques. And again, this is all kind of together in that integrated thematic teaching. We don't separate that out, we do that as we go along. So for example, we might think about assessing a tendon reflex. And again, you may be familiar with one of these. You may have heard about kind of looking at the patellar tendon reflex. And again, if you look on your workbook, you'll see a little picture of how this might be carried out. And again, if you're on campus, we'd try this together. But you may be able to stimulate this at home by perhaps using up a very tightly rolled up newspaper or magazine, and then perhaps trying to stimulate your tendon reflex by tapping your knee joint just underneath the kneecap and seeing if you can get that muscle to fire as a reflex from the actual nerve getting stimulated externally. And again, that's something we would carry out routinely for our patients to assess their neuromuscular pathway. If there is a problem, if we identify that the nerves aren't getting down to the actual muscles correctly, what we might think about is how we would treat that. So what are our treatment options? Well, one of the things we could do is something called Transcutaneous Electrical Nerve Stimulation, or TENS, TNS for short. And this can be used to treat nerve injuries and externally start to stimulate those muscles to contract again by providing an electrical impulse through the skin in lieu of the nerve not actually propagating the impulse correctly to the motor units. TENS can also be used for pain control. And you may have heard people that have bad backs maybe using a TENS machine, or people in labour giving birth also using TENS machines. It has multiple functions. Now, as I say, unfortunately, we can't get you to try this on each other as we would normally do. But what I've got here is I found a little YouTube clip you can have a little look at of how a TENS machine might be attached to a patient and how it's used. Unfortunately, I can't show you the videos that we've taken ourselves because I haven't got student consent to do that. Obviously, students aren't at university at the moment and I can't contact them easily. So the YouTube clip will have to suffice for the moment. Let's have a little look at this now.
Good afternoon. Today I will show you how to use the Transcutaneous Electrical Nerve Stimulation System, also known as TENS. So it is basically this unit with two electrodes that we will place on either side of the forearm, right below the joint. We will hold them in place with hypoallergenic tape, and we will use this gel to lubricate the pads. So let's get started. First off, I will lubricate one pad, like so. I will use the other pad to spread it across evenly. The other one will be on hold for a second. Place the electrode like so. And hold it down with the tape. Okay, we will do the same thing for the other side. Like so. Okay, once the electrodes are in position, we will need to adjust the TENS unit. First off, we will begin by setting the frequency. The frequency should be set to 70 Hertz. Secondly, we will set the pulse. The pulse needs to be set to 200 milliseconds. And the mode is set to normal because it's a continuous mode. Right up at the top, you have your amplitude. This will adjust the power of the machine. You're supposed to feel a slight tingle once it's on. You shouldn't feel any pain or discomfort. Adjust it till it's comfortable. Do you feel a slight tingle? It's not painful at all? Excellent. You will need to use this treatment once a week for 15 minutes for a total of 3 weeks.
Okay, so now we've had a little look at how TENS might work, and of course there are many different ways that we can work to treat muscle and nerve problems or anything affecting the motor units. But we've thought about nerves, we've had a little think about the muscles, we've had a little think about the bone anatomy of the lower limb, and we're getting a bit of an idea of how we might treat someone like Mary. We mustn't forget, however, the blood supply. After all, this patient has got that pathological process, which is the peripheral vascular disease, so poor blood supply to the limb. So our students would also need to think about the blood supply, not only to the nerves, which we know aren't working so well, but to the limb itself and the other vital tissues down there. So we teach our students how to think about assessing blood flow. And one of the easiest ways to do this is to have a little feel of the patient's pulses. And again, you can do that yourself now if you have a little look at your workbook. What I'd like you to do is have a moment or two, pause this presentation and see if you can't find your radial pulse and your carotid pulse. How you palpate a pulse or feel a pulse is quite simple. You use the pads of your second and third fingers, and the radial pulse is just below your thumb on the inside of your wrist, as you can see in the photos here. So again, in a moment or two, you can pause this and have a little try of palpating and taking your own radial pulse. Once you've done that, you can then have a little think about the carotid pulse as well. And again, this is relatively easy to find. If you have a little feel along your jawline and work backwards towards your ear, as the jaw starts to slope up, drop down to the soft tissues of your neck and pop again your fingers just in there. Don't push too hard. It should be relatively easy to find, and it's a big strong artery that you're palpating. And you can feel the pulsations underneath your fingers, hopefully. And again, what we'd ask our students to do is to kind of count the pulses and to consider the strength, the regularity, and the rate and rhythm. So again, perhaps now just pause this for a moment or two and have a little try of just palpating your pulses. Count the beats for 30 seconds, then times that by 2, and that will give you your beats per minute. And then we can have a little move on in a moment or two. Okay, so now you've had a little go at trying to feel your own pulses and had a little think about the blood supply to your own parts of the body, your neck and your arm. Our students would need to obviously understand how to do this at various parts of the body. So in Mary's case, we'd need to teach them how to assess the blood supply in the legs, for example. If you remember Mary's case scenario, she's got problems with her leg. So we'd have to teach them how to assess the vascular system, the blood supply, and that would include, amongst other things, palpating, feeling for the pulses in her lower limbs as well. And again, you can see the picture here on the screen of the different types of arteries that supply the leg, and you can palpate a pulse at any point of those arteries, so long as you know what you're looking for and feeling for, and as long as the blood supply is superficial enough to the surface of the limb. So, for example, we get our students in Mary's case and someone with a lower limb peripheral vascular disease problem to think about palpating the various areas of the lower limb. So, for example, here we can see in the left-hand side how our students will be able to palpate the anterior tibial pulse, which is just at the back of the ankle on the inside of the leg, as you can see. And again, we can see here how that anterior tibial pulse is propagated down this artery here, the anterior tibial artery, down to the front of the foot. Can you see? So again, it's our students will need to understand the anatomy of where the blood vessels run. Similarly, again, we'll ask our students and teach them how to palpate the anterior tibial at the front of the foot here, as well as at the side. We teach our students how to palpate again the various types of arteries in different parts of the lower limb. So here, for example, we're looking at palpating the popliteal pulse, which is at the back of the knee joint, deep behind the hamstring tendons we identified earlier. Again, our students would have to then think about how they would palpate the area of the groin, which is called the femoral pulse, which is just in here at the hip joint. Again, this is quite a personal area to palpate on patients, but we do have to be able to do that, and our students do have to practice doing that on each other as well. If we can't find pulses, and it's very possible with patients with poor blood supply, or we just are struggling a little bit because of a lack of skill, what we can do is use various machines called dopplers, which are small handheld devices here to enable us to find pulses, even though we may not be able to palpate them or feel them with our fingers. I'm going to flip over the slide in a moment or two, and again you'll be able to see then a student authored video. This is basically me teaching the students how to use the Doppler using one of their colleagues, and the students have the ability to be able to record us on our own cameras that we can upload to their virtual learning environment Canvas and StudyNet. So I'll pop over the screen just now and show you that.
Today I'm going to demonstrate how to locate the dorsalis pedis or anterior tibial pulse with a Doppler. First of all, I would think about where I'm going to look for the pulse, and I would usually search for it in one of these three areas with the Doppler. I'd ask the patient to relax their foot so that the tissues aren't too stressed. I'd dorsiflex it slightly, and then I'll use some ultrasound gel and put some on the foot. Next, I'm going to turn on my Doppler, and first of all, getting some gel on the probe end, I'm going to listen in this area here between the first and second metatarsal bones, sliding up the crease if necessary to locate the best signal. If I couldn't locate the pulse there, I would be searching across the middle of the foot, looking for the pulse at that site. Again, sliding slowly in the gel, not too much pressure on the skin. I'd usually be anchored to the foot with my other fingers, with the probe at an angle of about 45 to 60 degrees. If I failed to locate an audible pulse in that area there, I would next look for the anterior tibial pulse across the ankle crease on the front of the leg. Again, moving slowly, plenty of gel, searching for an audible signal.
So again, you've just seen how perhaps I would teach this in a practical class, and whilst it's perhaps not as polished as I would like it to be, this was done last year with my current students. And again, most of our practicals are actually recorded by the students on our video cameras, and we upload that to our virtual learning environment StudyNet, so they can go back and check how we've done stuff, how we've demonstrated the practical components of them, so they can revise and practice independently. So we've had a little think about the muscles, we've had a little think about the bones, we've had a little think about the nerves, we've had a little think about the blood supply. And with Mary's case scenario, unfortunately now things have moved on for her. And again, this is actually realistic. This is what unfortunately did happen. Her peripheral vascular disease has worsened even more, and that kind of necrosis we saw, that gangrene type of picture where the blood flow to the limb was quite poor and the limb was going pale, has resulted in Mary unfortunately undergoing a lower limb amputation. So again, now we need to think about teaching our students about lower limb amputations. So again, as said before, this results from gangrene, necrosis, and we can see a picture here of, again, that necrotic process going on, the tissues dying, where one side is quite pale. Here we can see the pale limb versus the kind of normal coloured limb. So we can see a distinct lack of blood supply to that limb, which has sadly caused Mary to have that amputation. So she's had a through knee amputation. So again, what we need to think about is going through with the students, and the students discovering the different types of amputation levels that might be carried out in clinical practice, and thinking about the pros and cons and why we might do one versus why we might do another. So here, for example, we can see the different common levels of amputation. Mary, as I said before, has had that kind of through knee amputation. So she's gone through the knee. The surgeon has disarticulated the knee joint. He has removed the lower portion of the knee joint, so essentially from the knee down has kind of been amputated, so it's all kind of disappeared. So from here down, that leg is no longer here. So that's the through knee amputation. The students will need to understand the pros and cons and the benefits and what that means to the patient in terms of their rehabilitation, which would go through in the theoretical and the practical and the small group tutorials that we do with our students. We also know that Mary's been a long-term heavy smoker. Do you remember her case scenario? She smoked 25 a day for 15 years, so she's had lots of problems with kind of potentially that nicotine and tobacco causing problems with her respiratory system or her lungs. Obviously, having surgery, having the amputation, Mary's had to have an anaesthetic, and this will affect her lungs and her ability to breathe. So post-operatively, again, as physiotherapists, we need to assess her respiratory system, and our students would need to understand the skills involved in that as well as the practical applications. So that would necessarily mean auscultating her lungs or listening to the various parts of the lungs to ensure that actually which areas are getting good oxygenation, which areas are getting good airflow, and which areas aren't, and are perhaps filled up with secretions or areas of collapse of the lungs as a result of the anaesthetic, which has been made worse by a history of smoking. We also need to understand chest x-rays and work out if we can find areas of consolidation where kind of the lung is filled up with fluid or secretions that we might be able to help them remove or improve their oxygenation by perhaps using various breathing techniques. For example, we may be able to use a non-invasive ventilator. You may have heard about these with the current coronavirus going on. And again, as physiotherapists, we're trained how to use these and how to apply them and how to improve someone's breathing ability. Mary, and after we thought about how we manage her respiratory problems and I've got her breathing again, cleared her lungs from any secretions so that she can actually start to rehabilitate. We then need to think about the next stage, which is obviously getting the patient, Mary in this case, back on her feet, to pardon the pun, and get her moving again. So we'd need to teach our students how to rehabilitate someone like Mary for through knee amputation. Think about exercise and exercise prescription. So again, in a moment or two, what I'd like you to do is just to pause this presentation and consider what kind of exercises you might prescribe Mary. Now again, if you're on campus, I'd get you to practice this with your fellow colleagues. But again, you may have a little bit of think about it in the comfort of your own home, and perhaps even try one or two of the exercises to see what might work for someone that's actually had a through knee amputation. So remember that below the knee, there is no more leg. So how might you exercise the muscles that are remaining? Have a think for a moment or two about how effective this might be and what adaptations you may need to make from the kind of thing that you could do to someone like Mary that's now had the through knee amputation. And again, recommence the video when you're finished. Okay, so some of the basic exercises we kind of teach our students to be able to use with the patients, particularly someone like Mary that's had an amputation, are some basic amputee exercises that you can see here. So the top left of the screen, you can see some static quadriceps where you'd lay there and simply tighten the thigh muscle down into the bed. The one underneath that is called a straight leg raise, where again you tighten the thigh muscle, but now you lift the leg straight up off the bed a couple of inches and work in those quadricep muscles. And again, try that if you want. Even without the amputation, you'll feel the muscles working. The top right on the screen, you'll see the through range or quads hip extension, and that's simply lying the patient on their side and extending their leg back behind them, squeezing the bottom muscles as they do so. Again, have a try if you've not done this. And the more straightforward exercise, perhaps the precursor to the top one there, is the static gluteal muscles exercises. When you're laying down or sitting up and essentially just squeezing your bottom and trying to push your bottom down into the bed at the same time. So again, have a try of those. And whilst they're relatively easy for us, for an amputee patient, this will be quite challenging, particularly after their early amputation. So again, our students would practice this in pairs and practice how they might progress these, make them harder, or regress them, make them slightly easier for patients that found this a challenge. So again, an example of what we might do in our practical sessions for our students to learn how to manage patients and interact with them and to rehabilitate them in the most effective way. So after we've done some exercises and Mary's getting stronger, we now need to think about how to teach Mary to stand and to walk again. And we'd start to do that using different types of early walking aids. So for example, one we might start with is called the PPAM AID, or the Pneumatic Post-Amputation Mobility Aid. And here you can see a picture of someone using this. Once they've mastered that aspect, we then go on to teach them how to use a prosthetic limb. And there are some examples here. So again, we have kind of models of these at university, and our students will get them out and have a little look at them, and I'll teach them all about the various pros and cons of using these prosthetic legs. Obviously, they can't try these on, but again, they have them there to be able to have a little look at and kind of rationalise when they would use them, when they wouldn't, and how they would teach the patient how to use them. So again, in class, what we do is teach the patient, the student, how to use these devices. So again, our last little video clip here is simply an instructional video from the makers of the PPAM AID, that device in the bottom left-hand corner, the kind of grey plastic bag and tubes. And this is similar to how I would teach it in the class. But again, unfortunately, I haven't got a video I can share with you because I haven't got consent from the students at this point. But again, you get the idea of how I teach it and what we'd do by looking at this video clip next.
Welcome to the PPAM AID fitting tutorial. We're going to start with the application of a below-knee patient. Before you fit the PPAM AID to the patient, you'll need to ensure that the stump wound's been assessed and a suitable cover applied, such as a soft dressing, clothing with soft seams, or a stump sock. You'll need to start by selecting the cushion bag and pumping in a little bit of air before folding the rounded end in on itself to form a small cup. This is then placed over the end of the stump so as not to cover more than the distal 5 centimetres. Do not attempt to insert the whole of the stump into the cushion bag. Holding the cushion bag in place, the outer bag's then pulled up to the patient's groin area. The correct length of frame is then selected by measuring against the remaining leg and slid up over the outer bag until the sole of the rocker foot's in the correct position. The ring at the upper of the frame should lie at least 8 centimetres below the top of the stump bag. The lengths are then checked by the physiotherapist. A foot pump is then attached to the PPAM AID. A pump with an accurate pressure gauge must be used. The PPAM AID must be inflated to 40 mm mercury before standing on it. It can be used to get the patient used to the pressure in the early stages by gradually increasing the pressure in a non-weight-bearing position. The patient should be asked to stand up by pushing up from the arms of the wheelchair. The physiotherapist may need to support the PPAM AID and help position it correctly for standing. Leg length should be checked by the physio's hands, checking the length at the ASIS. If needed, you can adjust the length by deflating the main bag a sufficient amount, and then re-inflate whilst the patient's standing. The sling support can now be adjusted so it gives support to the distal end of the bag. There will be some shortening with weight bearing, but this should not be more than 2 to 3 centimetres. The patient can now start to bear weight on their stump and walk with the support of the parallel bars. For an above-knee fitting, you'll need to follow a similar procedure to the fitting of a below-knee patient. It's advisable for the patient to stand during the fitting process. The patient should be asked to stand at the end of the parallel bars. You'll then need to select the above-knee bag and ensure it's fitted with the higher side to the lateral side of the stump. Please check that all loose clothing is folded carefully into the cushion bag to avoid discomfort. Thicker material such as denim works better to tuck into the back of the small cushion. This eliminates pressure and helps keep the bag in place. As before, a little air is pumped into the cushion bag. This time the cushion bag is folded in half and inserted into the outer bag. The correct frame is then selected and applied over the cushion bag. It's recommended that for above-knee patients, the crossbody shoulder strap is used for added security. The bag's then inflated to a maximum of 40 mm mercury. You must ensure at this stage that the patient is not weight-bearing. If needed, you can adjust the length by deflating the main bag a sufficient amount and then re-inflate whilst the patient's standing. Once the bag has been inflated and the length is correct, you can now adjust the distal straps. The patient can now bear weight and walk across the parallel bars. For further information, please visit www.ortho-europe.com or email us at info@ortho-europe.com.
Okay, so hopefully that kind of given you a bit of an idea of how we might teach some of the aspects of our physiotherapy program. It's a bit of a snapshot. It's a bit of a kind of a mix together of all types of sessions, but hopefully you can see how we'd use that kind of integrated thematic approach based on a patient scenario and how we'd tackle each issue in due course, but as a kind of a package together rather than leaving elements till later on in different kind of years, for example. We'd give you the whole package so you could manage patients with a condition right from the outset through to their kind of end rehabilitation. So it's giving you a bit of an insight into how we teach here and some of the techniques and resources our students can utilise when learning the kind of skills they require to become successful physiotherapists. Again, hopefully you've tried a few of these activities and hopefully you've had a little bit of a think about how it might feel if you're a student in the student's shoes, working and living at the University of Hertfordshire, and thinking about how we might be able to adapt our learning styles to meet your, teaching styles to meet your learning needs, for example. You've heard about some of the unique and positive attributes of our programme, and hopefully that's given you a good feeling about the University of Hertfordshire. It really is a very good physiotherapy programme that's held in high regard by lots of our kind of clinicians and clinical colleagues out there, as well as our students. So we do hope you'll be able to put us down as your firm choice on UCAS. We would dearly love to have you join us in September and kind of expand our cohort and also bring the attributes that you have to helping other people learn as well and becoming clinicians in the future. So we hope to see you again in September. If, of course, you have any questions, don't hesitate to drop me an email at the Physio Admissions email account. And again, I'm also going to be contactable for a chat online via the Uni Buddies scheme that you'll have access to just after watching this presentation on the website at the University of Hertfordshire. So good luck with the rest of your studies. Good luck with the kind of the isolation from the coronavirus. We will pass, I promise you, and we'll see you hopefully in September.